Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We're doing this program at the Alan B. Levan Innovation Center. Today we have a very exciting program to present to you. We have so many questions. You know, over the near 25 years that we've been doing these shows, we take questions from viewers, from John Q. Citizen and Mary Q. Citizen out there, and we try to give the answers. And we've got so many comments about the issue of prostate cancer, BPH, etc. Well, one of the experts is our guest. And let me introduce Dr. Ralph Zagha, and he's going to be talking about issues relating to BPH, and I would assume we're going to talk about prostate cancer as well. So welcome, doctor.
Thank you for having me.
Good to have you. You are a urologist working at the HCA University Hospital, which is immediately attendant to this university. We can wave at one another through one window to the other. It's a little distance, but if you get a binoculars, we can see one another. We have so many questions that have come to us, and that's what our shows are. Been doing these shows for close to 25 years, and we get questions from viewers, and we are so involved with questions that relate to prostate cancer and BPH, and we're very happy that you're available to help us. So tell us first what Aquablation is and why it's used.
Sure. So just a little background before Aquablation is what we treat. So Aquablation is a treatment of prostate enlargement, or also known as BPH. And BPH is a very common condition. As men age, it's almost guaranteed the prostate will grow to some extent, and that extent is primarily based on their genetics, possibly also environmental conditions. So we have a number of treatments for BPH, which initially start typically with medications, and then we move into different treatment options. Aquablation is one of these treatment options we offer our patients here at HCA University. It's a minimally invasive procedure, which is done without any incisions, under anesthesia in about 1 hour, and typically it's a one-night hospital stay. And what we do is we use this Aquablation robotic system that produces a water beam in order to open the prostatic channel to alleviate any obstruction for the urine emptying the bladder.
Okay, now the question that we get most often is it's difficult sometimes to urinate, but the other side of it is that I get up 2-3 times a night. So give me some thought process relative to that.
Sure. So when you meet with your urologist, there's a number of reasons why men will have voiding issues, from a weak flow to urinating often, day or night. And it's incumbent upon us to decide if that's primarily a prostate issue, a bladder issue, or even a non-urologic issue. As we age, we tend to start to make more urine at nighttime for other non-urologic reasons. Some of the things we cannot necessarily fix with medication or surgery, but we can address issues with prostate obstruction or difficulty emptying the bladder. So one reason at night why some men urinate often is the prostate grows into the bladder, can irritate the bladder, and also can not allow the patient to fully empty the bladder, so they're less efficient with their urination, cause them to void more often.
Also, what you mentioned about the recovery period, when you're talking about 1 day, usually after Aquablation in the hospital, but the recovery period is over a period of time at home as well?
So the recovery for the Aquablation procedure is typically just one night in the hospital with a gear. You're discharged typically the next day, and the catheter remains for a day or two at home before you take it out in the office. And there's really no recovery after that. As far as discomfort, there's some discomfort from the catheter, but not particularly any pain from the procedure itself. So there's very limited downtime.
Very limited. So I guess my next question would have been, because this is the question that we hear from the viewers, is what are the risks? And we already talked. You already basically given us what the benefits are, but and I would assume that because it's minimally invasive, by the way, which is a big, wonderful comments that come from our viewers about minimally invasive techniques. So what are the benefits? I think you've already spoke to it, but let's hear what you have to say.
Sure. So we could talk about the risks of the procedure first. For any procedure, there's always risk of bleeding or infection. Anytime you do a prostate-related procedure, there is some blood in the urine expected for some time afterwards, and typically it's very self-limiting. Infection risk is low. We give an antibiotic prior to the procedure. Longer-term risk, there can be risks of ejaculatory issues related to the sperm with ejaculation. There can be risk to scarring along that urethral channel from the procedure, called the urethral stricture, and that can happen with any prostate-related procedure. Actually, when the prostate heals, you're going to have a much better urinary experience with a better flow, voiding less often at nighttime and during the daytime, so you can empty the bladder more efficiently. And particularly to aquablation, we have the benefit to treat much larger prostates than we can with conventional prostate procedures we have available today.
You know, again, like I say, we get these questions and from usually viewers. So even though you've spoken to the aquablation, are there other additional alternatives to that, or is this is really the top of the game?
Sure. So there's a number of different procedures for prostate enlargement. The traditional procedure called a TURP, a transurethral resection of the prostate, is a similar type procedure done with minimally invasive technique and not cutting the patient. You're limited to how large of a prostate you can treat with the TURP, whereas aquablation, you can treat much larger prostates. There are other techniques for very large prostates, some of which would include an embolization procedure done by interventional radiology, other laser procedures such as what's called a HOLEP, where you enucleate the prostate, minimally invasive. So we have other techniques involved and available for very large prostates.
With reference to that, your presentation of to that question, we also hear a great deal. I guess there's a tremendous fear out there because of the knowledge or the communication that's occurring in media and otherwise relative to prostate cancer. Is there a methodology which should be dealt with prior to or at the same time that you do aquablation?
With regards to prostate cancer?
Yes, sir.
When you see a patient for prostate issues, whether it's enlargement or cancer screening, as a urologist, we basically have screening recommendations from our guidelines. At age 50, we like to screen men for prostate cancer. Sometimes we start at age 40 if there's a high family risk with prostate cancer in the family and fathers, brothers, uncles. That screening consists of a digital rectal examination, typically, as well as a blood test called a PSA. So we do that ahead of time of the aquablation, typically. So we want to ensure that there's no prostate cancer or active prostate cancer while treating with the aquablation procedure. By doing any prostate procedure such as aquablation, we still perform cancer screenings afterwards, as there's still a rim of prostate tissue left behind. So even after these procedures, we still perform digital exams as well as a PSA test.
Relative to PSA, we had another question from a viewer because I guess you see things in news media or newspapers, although very, the newspaper reading today is down to most places there are newspapers that have gone out of business, and there's only about 20-25% readership of many newspapers. But there are questions about PSA that have been released by various elements of healthcare, I guess you could say, agencies, both from the federal government to the various large corporate hospital entities and otherwise, that talk about the change in the question of what level of the PSA should be indicated as having a problem. So maybe that's an oversimplistic question, but I think you know what I'm talking about.
Sure. So it's a very complex and controversial discussion as far as PSA screening. And as you say, there are different recommendations from different associations, ranging from do not PSA screen as they do in other countries. There's no PSA screening recommendations in for example, England, all the way to what we recommend PSA screening age 50, up until the point where we feel that there's less than a 10-year life expectancy. So typically in the 70s or 80s. As far as the cutoff, you'll see on the lab test, the cutoff is typically 4, although this is very arbitrary. So typically we use different cutoffs based on the patient's age, their overall health, the prostate size. As the prostate grows, your PSA can go higher for non-cancer reasons. So we take all that in consideration. It's not a very sensitive test to prostate cancer itself. We also look at prostate change in the PSA, the velocity of change. So PSA increase is something that we're very astute to. Other tests coming out now, such as free and total PSA, 4K score, which is genetic biomarkers, or MDX, which is a urine test biomarker, as well as MRIs are other modalities that we're using now to sort of hone in on patients whose PSA might be high, and we want to avoid testing or biopsies or other interventions that we can maybe avoid.
Now, this might be an odd question, but this was a question that came from, I shouldn't say it was odd, it was just interesting. The person who sent the question in about PSA said that he's age 72, and he said that his PSA is 4.3, 4.4, and it's been like that for the last 3 years. I'm not asking you to offer advice to that one person, but is that a very common thing, or is that what is the red light that lights up and says, I think we got to go a little further than just getting a PSA test?
Sure. So again, typically, it's as you get older, a 72-year-old having a slightly elevated PSA of a 4.3 would not necessarily be alarming to me, especially if he had a stable range in the past. That's typically something that I would have a discussion with the patient and give him options, and typically we keep an eye on that PSA and not jump to additional testing at that time.
Right. Well, again, I think it's a very good thing for us to be discussing this issue because, again, as you know, because I'm sure that you must be sitting on a lot of panels and you're involved with the various specialty organizations that are involved with urology. But there's such a dearth of questions that are coming to us with reference to the issue of prostate cancer. Let's take the people who are viewing us and take them through a period of time. When should they be tested for PSA, or should that be part of the regimen of a blood draw at all times in life, et cetera, et cetera? So I'll give it to you, and it's all yours.
Sure. So again, the guidelines differ based on specialty. For the urology guidelines, we recommend PSA screening age 50, but sooner, maybe age 40 if there's a strong family history. And we perform annual PSA screenings up to the age, let's say 70 or so, or a 10-year or less life expectancy. If you're a healthy 70-year-old or 80-year-old, sometimes we do continue PSA screening. And again, the screening is done in conjunction with a review of your prostate size, your overall health, and your prior PSA numbers. The treatment of prostate cancer has also changed dramatically over the past few years. And as you mentioned before, prostate cancer is almost guaranteed as we get older. So we're trying to adjust treatment to that sense that it may not affect you during your lifetime. So we wouldn't want to intervene unnecessarily causing side effects for certain low risk or low grade early prostate cancers. On the other hand, prostate cancer can lead to numerous deaths. It's the number 2 cause of cancer death in men. So we were trying to accomplish treatment for the appropriate patient with limited side effects without treating the entire population.
You know, there are so many items that are viewed on television ads, when you get onto your computer and things come up talking about issues related to sexual capabilities and things of that nature, which all relates to what I would call the privilege of having good health care screening by people such as yourself and your colleagues. So does that get into your daily or functioning features of being a urologist, hearing all of these things? What is your suggestion to the John Q citizens that are talking like this about these issues?
Sure. So any way we can get men to see their primary doctor or urologist for prostate cancer screening is a good way. Women typically are better healthcare users and they're more active with their physician, their gynecologist, performing mammograms. Unfortunately, men are more difficult to get to their provider. And we get them in different manners, like you said, through TV, through advertisements, through family members, through friends who may have gotten prostate cancer or recent diagnosis. And any way they can get to us is great. Unfortunately, prostate cancer and prostate enlargement is something that we have little control over personally, meaning that you could be a healthy person and develop this regardless of eating well and exercising and not smoking. So it's still important to see the physician to get your annual check, just like you would a colonoscopy. So any which way they can come to see us would be a good way.
You mentioned earlier in our conversation about the genetics. Is there a genetic screening that would be recommended to relate to, or is just a presentation of the knowledge by the patient to you, the physician, and your fellow urologists relative to family history?
Sure. So this is an exciting time for cancer research, and we're just starting to scratch the surface of genetics and genes involved in cancers. So there are some proprietary genetic screening tests called the 4K score, called the MDX. They use genes to risk stratify and basically help us decide the next step in the patient's care. There's also geneticists, physicians who specialize in exactly what you're speaking about, who, let's say a patient comes in with a very early diagnosis of prostate cancer, for them to see these physicians to see if there are any active genes that we can identify and then maybe notify family members. So that's basically the next step of cancer research and treatment.
Well, I think that's really very important, because there are so many people now that are at least from our perspective, we're receiving so many requests for information about prostate cancer. I guess it's the very formidable communications that occur, like I said, on the various either television networks or advertisements, or on your computer or cell phone, whatever, relative to these comments that come from the various organizations. And prostate cancer is definitely in one of the top 2 or 3 issues that come to us, and that's why I'm so pleased to have you available to communicate what you have communicated. So I'm going to leave the rest of my comments sitting here and listen to what you would suggest a person should and will do.
Sure. So for any health issue that a patient may have is to see your doctor. As you mentioned, as far as any urinary change for urologist, to see your physician. It may be a natural cause of aging that we could just reassure the patient, but it may be the signs of developing prostate issue, maybe a sign of developing prostate cancer, other issues we deal with. We could check into that as well. But it's basically listen to your body, and if anything is abnormal or unusual, to see the doctor. But also screening issues that you're not going to feel any change until it's too late to see your doctor about, such as your PSA screening, your colonoscopy, your primary doctor, cholesterol, diabetes. So to stay active in your own health care, to stay active in your consultants and your screening tests is very important to every patient.
There's another thing, and I don't know whether there's any linkage, but there's been a question came to us about nutrition and I guess you could say the intake of fluids. Do you have any comments relative to certain nutrition or intake, food intake, or obviously liquid intake?
Yeah, so there's limited studies on nutrition, prostate health as far as what we should be doing. There's some linkage to patients with high red meat intake causing or associated with prostate cancer. As far as fluids, there's not really any great studies for prostate cancer or prostate health. Just to stay hydrated and drink plenty of fluids, of course, not before bedtime if you want to avoid waking up at night. But we just recommend overall heart healthy diet, exercise, and a good fluid intake.
You are basically a subspecialist within your subspecialty. How does the individuals get to your type of presentation of your subspecialty? Are they referred by colleagues, other urologists, by internal medicine folks, family doctors, etc.?
Sure. So depending on the patient's insurance plan, some patients find us through internal medicine physicians. Some patients find us through emergency room referrals. Some patients can go directly to the specialist if their insurance allows it. And then within the urology community, not every urologist does every procedure. So we also refer to our colleagues, different patients who could benefit from even super specialized care.
Well, there's no question aquablation is relatively new in the world of healthcare. Isn't that correct?
That's correct. So it's been out for a few years. University HCA obtained the Aquablation machine just a few months ago, and we're treating a number of patients. They're all done fantastic. We're very excited to have that technology here.
Well, we're really pleased that you're here in South Florida, very clearly in Broward County, and you're a neighbor.
Yeah, so I had amazing training from med school at Tufts, stayed in Boston for Mass General, 2 years of surgery, and then a Leahy Clinic with some experience at Boston Children's. We had a tremendous exposure to all aspects of urology, which I was able to bring down to South Florida. And I've been here for the past 18 years and enjoyed and been an honor to practice in our community.
Okay, well, thank you very much. I see there's someone at your left-hand shoulder asking you to better get out, and you got a patient waiting for you. So we're going to let you do that. See, she didn't know that I knew that she was there, but her purse got into the picture, and so I know that she's there.
We have Aquablation patients waiting.
You got it. All right. Well, we thank you very, very, very much. Again, Dr. Zagha, wish you well. We welcome you to our community right here in South Florida. And anytime that you think of us, think of Nova Southeastern University and our students, and they could learn an awful lot from you. So thank you very much for your time today. And we want you to know that, as I say to the people that are viewing, please, something's bothering you, tell your doctor. Don't keep it a secret. Don't walk into a pharmacy or walk into a supermarket and buy something and think that that's going to help you just do X or Y. Anyway, thank you very, very much. We appreciate it. My name is Fred Lippman. We come to you from Nova Southeastern University. If you have a question or you need an answer, there's a telephone number and an email address. Until next time, see you.